Afternoon. Thank you so much for joining us for this faculty panel hosted by NYU Rory Myers College of Nursing. Our panelists here will address health equity through the lifespan. As gaps in health continue to grow across the nation, healthcare system has become more fragmented and the demand for workforce development has increased. Our panelists will explore priorities in healthcare delivery and equity in health trajectory for the youngest, oldest, and the most marginalized in our community. This program will award 1 continuing education, nursing education contact hours, and after the program, we'll email you the survey to be completed in order for you to receive a contact hour. So I'd like to introduce our panelists. First, Dr. Audrey Linden is the Assistant Dean for Clinical Research and a professor at NYU Rory Myers College of Nursing. Her research focuses on safety, communication, and teamwork in maternity and neonatal settings, and examines the perspectives of clinicians and parents on maintaining safety in the perinatal environment. And we have Dr. Anne Margaret Navarro, is an assistant professor at NYU Rory Myers College of Nursing. Her current research interests include design and implementation of technology-supported behavioral interventions for improved disease self-management among HIV-infected youth. She's an NIH-funded researcher and board-certified pediatric nurse practitioner. Dr. Allison Squires is an associate professor and director of the Florence S. Downs PhD program in nursing research and theory development at NYU Rory Myers College of Nursing. She's currently leading the international arm of a COVID-19 study that examines how the global pandemic has affected clinical nursing practice on the front lines. Domestically, her research focuses on improving immigrant and refugee health outcomes. Dr. Squires will be our moderator today. And Dr. Jasmine Travers is an assistant professor at NYU Rory Myers College of Nursing. Her career is dedicated to designing and conducting research to improve health outcomes and reduce health disparities in vulnerable older adult groups. Her current work focuses on mitigating disparities in appropriate access and use of in-home and facility-based long-term care for older adults. And we'll begin by having each faculty member share an overview of their research. So Dr. Linden, I'm going to turn this over to you.
Thank you so much. And thank you for inviting me to be part of this panel. It's really a pleasure to be here with all these terrific folks today. Janet, can I have the next slide, please? What I'm going to be talking about today is maternal morbidity and mortality. Many of you have probably heard that we are in a pretty big crisis in maternal health in this country at this time. Sadly, despite enormous reductions in maternal mortality during the 20th century, maternal mortality has actually been increasing in the US since the mid-1980s. And is more than double now. The rate is more than double now what it was at that time. So the numbers on this graph represent the annual deaths among women and birthing people if during either their pregnancy or within the first year of life following the pregnancy from any cause that was related to or aggravated by the pregnancy. It's reported as deaths per 100,000 live births. So that translates in the US to a current maternal death, and the number of deaths is about 700 per year. And what is tragic about this, in addition to every maternal death, has an enormous effect on individual families and communities and a ripple effect beyond their immediate circumstances. What we've come to understand from doing very careful reviews of maternal deaths is that at least 60% of these deaths are deemed preventable. And that is probably a conservative estimate of the number of deaths that could be prevented. In addition to that, there are some related problems, very serious pregnancy complications that people survive, but they may have long-term long-term consequences of those serious pregnancy complications. This is called severe maternal morbidity. And it's also rising, and it's now about 100 times more common than maternal death. So that affects 50 to 75,000 families per year. And in both cases, the maternal deaths and the very severe complications are both preventable problems for the most part. Next slide, please. Even more important, or additionally important factor here is that the maternal health crisis, the pregnancy-related mortality crisis, is fundamentally a crisis in health equity. Unfortunately, there are significant disparities and inequities in birth outcomes, both maternal and infant, actually, but we're just going to talk about the maternal ones today. Maternal death rates are much higher in American Indian and non-Hispanic Black populations than they are among Asian or Pacific Islander, non-Hispanic white or Hispanic or Latino populations. So at least 3 times the number of deaths occur in the non-Hispanic Black population. And then also with severe maternal morbidity, that is, again, more common in Latina, Black, and Indigenous women and birthing people. So this is a serious problem. In addition to that, Black women are also more likely to report mistreatment and abuse by healthcare providers during their pregnancies and birth. We're starting to see more and more work be done in that area, where we're documenting that, surprisingly, there is a large amount of abusive behavior that occurs during healthcare in the United States. And in addition to all of this, the gap in New York City itself is even larger. The outcomes for women and birthing people in New York, especially those of minoritized populations, are much higher than they are nationally. So we have a significant problem on our hands. Next slide, please. One of the things I want to focus on today is some of the things that we've done to try to address this crisis, and then where we need to go in terms of it. So early recognition of the rising maternal mortality rate in the early 2000s led to a big initiative to improve hospital-based care during the childbirth hospitalization. So for example, in California, where I worked for 15 years before coming to New York, we designed and implemented toolkits for healthcare providers to help them more effectively respond to emergencies during labor and birth, and to help hospitals better handle these situations and learn from them. Statewide implementation of those toolkits was part of what helped reduce pregnancy-related deaths in California to less than half the national rate. California's maternal mortality rate in 2016 was 5.9. Which is significantly lower than the rest of the country. So that has been really important, but unfortunately, we haven't seen a decrease in the gap in terms of the difference between outcomes for example, Black women and white women, even in California, where so much work has been done. The CDC recently published a close study of pregnancy-related deaths and identified factors occurring at multiple levels that contribute to those deaths. Everything from patient and family, lack of knowledge and non-adherence, up through healthcare providers, healthcare systems, and our social system. So what I want to argue here is that actually we could think about all of these factors in terms of system level accountability for what is going wrong in healthcare. For example, at the patient level, lack of knowledge and so-called non-adherence to treatment really may have more to do with our inability to meet patient needs the way that healthcare is currently structured, with very short appointments, maybe a lack of resources in terms of interpretation. We know that actually the vast majority of Americans do not have a high level of health literacy or ability to understand the language that we use when we talk about healthcare. So all of these things have to do with how our system is organized, more so than being something that we can say is to be laid on the patient themselves. We also know that we have significant issues with healthcare providers, where there's a lot of bias and discrimination that occurs during care. And this has to do with allowing behavioral norms to continue that permit that type of behavior, and also with are we need to have a much better understanding of what it means to be culturally humble. And we have a long way to go in terms of developing a more diverse workforce where people can have culturally concordant care. We have also allowed a continued culture of hierarchy, poor communication, and dismissiveness towards patient expert knowledge of their own bodies. And this, when you put that together with stereotyping and discrimination, we have many patients who know something is wrong, but are not able to get healthcare providers to listen to them and act on their care. You may have heard, for example, the highly publicized case of Serena Williams, who had a complication after birth, knew what it was, brought that to the providers, and was not listened to, and had to really strongly advocate for herself. Our research has also shown how difficult it can be for healthcare providers to speak up when they know something is wrong, or they have a safety concern about care, because they fear retaliation within their environment and even potential job loss. So, and this is not something that is only a feature of nurses or medical residents. It cuts across all levels of healthcare providers. So again, to me, this is a system problem that we have allowed that type of culture to continue, and we need to get our healthcare systems to set standards and focus on values that provide a different level of support and respect for all individuals. We also have a safety net that is extremely fragmented, and we have not understood or not paid as much attention to how things like unstable housing, lack of transportation, actually contribute to poor outcomes and require policy action to create a more seamless integration of services for people who are having birth. Next slide, please. Finally, there's also a tendency to try to explain increasing maternal death and racial disparities through individual characteristics, such as patients being older, sicker, or heavier. Something that my colleagues, Dr. Monica McLemore and Dr. Karen Scott, have described as mother blame. And I want to emphasize how important it is to understand that exposure to structural racism is what drives health disparities and disparate outcomes. And we have to change our approach from that of cataloging disparities to conducting research and providing healthcare that is doing something about addressing those structural issues. Illness and poor health are due to the transgenerational embodiment of discrimination and structural inequity, and we have to change how we think about what we're doing in healthcare. Next slide, please. So I would argue that it is now clear that focusing just on the traditional way of thinking about health systems is not enough. We have to center community voices and solutions. We have to define new norms and cultures inside of healthcare systems that are founded on anti-racist praxis and a respect for personhood and expert knowledge of each individual engaging with us for care. We have a lot of knowledge that we can bring, but so do the people who come to us for care, and we have to do a better job of walking together through care instead of telling people what they need to do. We also need to cultivate different kinds of collaborations where we bring together many sectors, so finance for housing, and social services and healthcare, and bring them together in the same space to create new solutions. And those have to be done in centering the communities that we are trying to serve. Finally, we need to diversify the healthcare and scientific workforce. And by that, I don't just mean recruit people to come in, but also build a culture where we can retain those folks within our systems, and they can be contributing to a different way of thinking about what we're doing. And then nurses are also change makers in healthcare and health systems, and are the largest sector of the healthcare workforce that cares for childbearing families. But nursing remains hidden in the current discussion around the potential solutions, and we need to really think about how we could re-envision the vast workforce of staff nurses who work with childbearing families in order to better meet community needs. So those are some of the thoughts I have about where the science needs to go to address this pressing problem in the United States. Thank you.
Thank you. I am Ann Margaret Navarre, Assistant Professor at NYU Myers, and I will be talking about HIV health equity 4 decades later. Next slide, please. So in June of 2021, we celebrated 40 years of progress in HIV, as the first reported cases of AIDS were in June of 1981. This was reports of 5 young men who all were homosexual or gay, who had this pneumonia called PCP. And shortly after that, there were reports of unexplained immunodeficiency in children under 2 years of age. And this was in December of 1982. Next slide, please. So I'm really going to date myself now. I began my HIV career in June of 1992. And this was at the peak of age-related mortality, as you could see from this graph. The leading cause of death among Black men ages 25 to 44 was AIDS. And this was above other conditions here listed on this slide, such as heart disease, cancer, suicide, liver disease, stroke, etc. So in December of 1992, there were about 250,000 reported cases of AIDS. And of this number, 4,000 were children. Next slide, please. So there have been much progress that has been made throughout these past 40 years. And one of the biggest milestones as far as improving mother-child HIV outcomes was the ability to prevent mother-to-child HIV transmission. So at this point, I was working as a nurse practitioner for just about 2 years. And at that point, HIV-infected pregnant women, if you had 10 women who were pregnant, at least 3 of them would have a baby who was infected with HIV. This is without treatment. So there was a clinical trial called 076. And in this trial, if you gave AZT to the mother during pregnancy and labor, AZT to the infant for the first 6 weeks, you were able to decrease the transmission rate to as low as 8%. So instead of having 3 out of 10 cases of HIV infection in infants, it went to 1 out of 10. So this was a major breakthrough, so much so the trial was interrupted and this was offered as standard of care. Today, this certainly continues, although it is a combination antiretroviral treatment and also avoidance of breastfeeding and a C-section when needed. But the key here is that if we are going to prevent mother-to-child HIV transmission, you need to have access to prenatal care. Next slide, please. Another major milestone, this was in 1996, was the advent of highly active antiretroviral treatment. And this truly transformed HIV from being a uniformly fatal illness into a chronic illness. That's if you take your medications. Now, I have to admit, during this time, the picture that you're seeing on this screen, it was not uncommon for HIV-infected young people and adults to be taking handfuls of medications. Today, we have much better dosing formulations, including monthly injectable formulations of HIV medication. Next slide, please. We know also that effective treatment equals prevention. Another big breakthrough over these past 40 years was that we learned that if you have an undetectable viral load, meaning that the amount of HIV in your blood cannot be detected through standard assays, sexual transmission is negligible. So again, effective treatment equals prevention. Next slide, please. Okay, so as I said, effective treatment certainly equals prevention. And we know that sexual transmission is negligible if you have an undetectable viral load for 6 months or greater. So as far as where we are today, there is a bold plan to end the HIV epidemic. And in 2025, the goal is for a 75% reduction in new infections. And as far as what these key actions are to help end the HIV epidemic, it's testing, certainly knowing your status, treatment for people who know that they're HIV infected, and prevention for people without HIV who are at risk of HIV. As you can see, we have some way to go to meet these targets, especially when it comes to PrEP. As far as people who have a PrEP prescription, it's 18%, where the target is 50%. Next, actually, I'm forwarding the slides. So where are we today? As I said, we have the treatment, we have the prevention, and we have some of the tools to really end this epidemic. But yet today, there are 1.1 million individuals living with HIV. And certainly still today, gay and bisexual men are the population that are most affected by HIV. And this includes Black and African American men, followed by white men who have sex with men. But please note, you also have a category here of Black and African American women who are acquiring the disease through heterosexual contact. As far as perinatal infection, as I said, mother-to-child transmission, in the United States today, the transmission rate is less than 1%. And in 2018, there were less than 100 infections, new infections, mother-to-child infections, I should say. But please note that most of these infections were among Black and African American moms and their babies. As far as young people in the HIV epidemic, you could see that these numbers continue to come down. However, in 2018, there were nearly 8,000 young people. When I say young people, these are ages 13 to 24 who were infected. And this represents about 21% of the total of infections in 2018, which was nearly 37,000. And why is this? Why do we still have so many young people who are being infected with HIV? Well, for one, there are many developmental considerations. These are emerging adults. Their peer relationships are of utmost importance. This includes issues of sexual and emotional intimacy. There's certainly HIV disclosure concerns related to stigma. This lends to facing many challenges with antiretroviral treatment and adherence to treatment, again, related to stigma. But we also know that more than 40% of young people who are infected and they start care, they're not retained in care. And that's really a problem with the healthcare system, not with the young people. There are also prevention challenges for partners. There's low uptake of testing with PrEP and high rates of STDs. So although we've made much progress, HIV is a chronic illness with good life expectancy. That's if you take your medicines and stay in care. We have tools to treat and prevent HIV infection. We can prevent mother-to-child HIV transmission in the United States. There's options for testing. We have syringe exchange programs. There's still much unfinished business. And one of the highest priorities I see is to confront the stigma, discrimination, and the racism and bias. It's really difficult to access support if you're uncomfortable disclosing your HIV diagnosis, or if you anticipate that you'll be confronted with stigma or discrimination in the healthcare system. This certainly does not lend uptake of PrEP or some of the available antiretroviral treatments. We also know there are population-specific disparities. As I said earlier, one of the highest or upcoming highest risk categories are Black and African American women who are acquiring the disease through heterosexual contact. We know there are issues with prenatal care for childbearing women or women of childbearing age. There certainly are substance use and mental health issues. And it's also really difficult to manage a disease if you don't have basic housing and insurance coverage. We know that there's great promise with technology, but there is a digital divide. You're going to have access to telemedicine or some of these technology-enabled interventions, you need to have a smartphone that has uninterrupted access. And you also need to live somewhere where you have good internet coverage. So as far as what do we do about this, there's really a need for multi-level combination approaches. In our current trial, we have mobilized peer health coaches, and the peer health coaches are here at Myers, and they're connecting with individuals in the community using smartphones that we provide through the study. So far, our pilot data has shown that this is feasible and acceptable, and we're right now starting up this trial. So we'll have more information to come. As far as nursing and HIV health equity, I just have to give a real shout out to my fellow nurses. Nurses have been frontline pioneers since the beginning of this epidemic. I do have some real concerns given our current nursing shortage and the impact of COVID. Nurses have played an important role in policy development, treatment and care, as far as testing, PrEP and adherence support, and helping retain individuals in care. And they've certainly done a lot with advocacy and education. I know that we just cannot end this epidemic alone. We need partnerships, and these partnerships need to include nurses, especially in the healthcare, research, and community arenas. Thank you.
Thank you so much, Dr. Navarro, for that excellent presentation. Alrighty, so we are going to now get to the other end of the spectrum, thinking about older adults, long-term care, and the aging nation that we are in. Next slide, please. So currently we have an aging nation. Here I show graphs reflecting the population age 65 and over for the United States over a time span from 2012 to 2050. And back in 2012, we saw a little over 40 million older adults, 65 years of age and older. And that number is expected to grow to 83 million people by the year 2050. And interestingly enough, is right now where we stand, that group of older adults is more than those who are under 5 years old. And by 2050, even by 2035, that number will surpass the age group under 18. So a lot of older adults, and it's a great thing. So percentage wise, we started off less than 15% in 2012, made up our population, older adults. And by 2050, there will be greater than 20%, 65 years of age or older in our country. So that's about 1 out of every 5 individuals will be older adults. So we're growing, we're aging, and this is something we should be excited about, because many times when I talk to people, and we talk about, aging, getting old, and people say they don't want to get old. And if you don't want to get old, then that means you want to die young, right? So I think this is something we should be celebrating, and then also thinking about what does older adult age look like for us. So coming up with this older adult age, we see a growing number of population that's going to also need long-term care. That's 70% of individuals who will need some type of long-term care services in their lifetime once they're 65 years of age or older. And that's 2 out of 3 older adults. Next slide, please. So what is long-term care? It involves a variety of services designed to help people live independently and safely as possible when they can no longer perform activities on their own. And one thing I want to clarify what long-term care isn't. We have to think about, just because people need long-term care doesn't mean they want to stop, or just because people need help with living, so when thinking about what long-term care provides, doesn't mean that they want to stop living. So let's see some of the activities that one might receive support in when it comes to long-term care. Next slide, please. So these activities that people can receive assistance with include eating, bathing, dressing, transferring from chair to bed, toileting, or just walking around, moving around. And these are known as the activities of daily living. And these types of services and supports can be provided in institutionalized settings, such as nursing homes, or they could be provided in assisted living or in home and community-based settings, such as in the home with formal paid services, such as a paid caregiver, or informal services, such as a family or friends. Next slide, please. So we came here to talk about equity, and that's what a lot of my work is rooted in when thinking about ensuring that older adults have equitable access to long-term care. And one thing that we can spend some time on is defining what is health equity. And this is actually a new equity perspective that I've seen. I typically see the one at the baseball field, but it all means the same thing. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. And as we're measuring this, and in my work, it means reducing and ultimately eliminating the disparities in health and its determinants, and we talked about determinants before, that adversely affects excluded or marginalized groups. So for me, when it comes to my work, ensuring that people have access to quality care, that they're able to afford that care, and that they are able to receive services and supports and resources just like the next person, no matter who they are, their background, racial and ethnic background, their socioeconomic status, their geographic location. Next slide, please. So let's look at equity in the nursing home space during the COVID-19 pandemic. And here last year, there was a study done where we looked at 11,000 nurses. I'll go ahead and just, 11,000 nursing homes. And within those nursing homes, we were looking at the COVID cases and the COVID deaths. So the number of COVID cases and COVID deaths at the beginning, early on in the pandemic last year, we saw 283,973 COVID cases, which made up 12% of the entire cases in our country. But there were 56,000 deaths within the nursing home space. So that made up 44% of all COVID deaths in the US. And we have to think when it comes to those types of numbers, first, what is the inequities that are present in that? And I would say the first one is the permissibility of deaths in this setting. And I'd like to compare it to this. If we saw 44% of all COVID deaths in a childcare setting or in a school setting, we would never even be able to live, we wouldn't continue living to talk about it. So the question is why did we permit such, atrocities in the nursing home setting? And then the second thing I would say in regards to inequities is the poor vaccination plan for older adults. When it came to older adults and vaccinations, we knew that they had to be prioritized. They had to be the first ones in the line, right? But when it actually came down to rolling out the plan, there wasn't much that was put into addressing how older adults were going to get to the front of that line. And we saw that when it came to securing vaccination appointments, getting to vaccination sites for older adults, and then actually being able to wait at that site, if depending on if there was a line or the extremities of the conditions of the weather and such. So those are some inequities that we see within the nursing home space, and we question why are those inequities existing when it comes to the types of care that one group receives compared to another, or the types of responses, emergent responses, and one group receives compared to another. Some of that may be actually rooted in biases that we might have and stigma that we might have when it comes to the older adult population. Next slide, please. So some additional areas of concern when thinking about equity towards older adults and in the long-term care space. So first, we'll focus on the staffing and workforce issues within nursing homes. Let's just take a look at that. So early on in the pandemic, nursing homes reported shortages in a number of staff. So about 16% of nursing homes reported shortages in licensed nurses, so registered nurses and licensed practical nurses. 18.4% of nursing homes reported shortages of nurse aides, and then 2.5% of nursing homes reported shortages of clinical staff. And we know shortages of nursing staff, RNs, LPNs, and certified nursing assistants were all associated with poor COVID outcomes, COVID infections, and COVID deaths. And then next, during the pandemic, we already have a shortage of staff, even before the pandemic. But there is a high intention for individuals to leave the nursing profession. So in a survey that was conducted, 22% of individuals who completed that survey said they intended to leave the nursing profession. And then next, of course, we saw decreased work satisfaction among staff, and that's because of many factors. Staff feeling that they weren't being listened to, they weren't being cared for in the ways that they needed to be cared for, not feeling valued, not being at the table and being part of decision making, and then feeling that they're not being paid in ways that they need to be paid and supported in other ways, and not having the actual resources to be able to do their job and the knowledge and information. So next area is health outcomes. So the health outcomes that we saw, there were per 100 beds, 20%, close to 20% of staff had a confirmed COVID-19 infection, which is quite high when thinking about staff and experiencing COVID in nursing homes. And then next, with health outcomes, we saw that 30% of residents per 100 beds had a COVID-19 infection. And then amongst staff, we saw an increase in chronic fatigue. And then lastly, some disparities just to note. So when looking at, we can go ahead and go to the next one. When specifically looking at nursing homes with a higher number of racial ethnic minority residents, specifically Black residents, a high proportion of this group, these 22% of these nursing homes reported a shortage of staff. So we see nursing homes with an increased number of Black residents having less staff compared to nursing homes with no Black residents. And additional disparities that we see in this setting, close to 90%, pretty much 90% of nursing homes with a large proportion of Black residents, so that's 50% or more, report at least one COVID-19 death compared to 60% of nursing homes with no Black residents. And then lastly, this was looking at vaccination rates among aides, nursing aides, and nursing aides that lived in areas with higher proportions of racial and ethnic minorities. 43% had a COVID vaccination compared to 50% of nursing aides that did not live in areas of high proportion of Black residents. So potential solutions to strengthen the inequities and poor care that we're seeing in nursing homes, and just areas that we need to strengthen when it comes to staffing. So I would say starting off with reframing long-term care. So creating a society that recognizes that just because one needs help with living does not mean they want to stop living, and build nursing homes that reflect this sentiment. So putting the care back into nursing homes and making nursing homes look like home environments as opposed to a ward in a hospital, or in some cases, it's referred to as a prison cell. So thinking about what that looks like, and also how we as a society actually approach aging, because that will influence the types of attention that we put towards these settings. Next, I would say revamping the staffing model. We need to increase staffing in general when it comes to the nursing homes setting, and address the low pay and high stress nature of the work. So over the course of the pandemic, the certified nursing assistant position, for example, was rated as one of the most dangerous jobs during the pandemic. So thinking about better pay and benefits to avoid any future chronic shortage. And then as we're recruiting staff for these positions in nursing homes, we also need to kind of think about where staff are trained. So going back to nursing settings or universities where nurses are being trained, and introducing experiences with nursing home settings. So in the clinicals, building those relationships and partnerships so that people can actually see themselves working in nursing homes as opposed to only hospitals. Then next is prioritizing equity. So set a standard for equity in nursing homes and do not tolerate inequitable and poor care. So just like you wouldn't tolerate a patient, for example, kicking a staff member, that's the same thing that we shouldn't tolerate inequitable care or inequitable treatment to residents and staff. And then lastly, we need to institute better support. During the pandemic, nursing facilities received funds from the CARE Act, as well as another initiative under the CARE Act, which was the Paycheck Protection Program, that provided funds to go towards staffing. But these are temporary solutions. We need to think about what longer term solutions look like to support nursing homes, and then institute early warning systems that are going to be able to really truly support nursing homes from the beginning and throughout these issues that they're going through. And next slide. And thank you. That is my short presentation on long-term care and aging and priorities.
Thank you, Jasmine. We are now going to switch over to a little bit of Q&A with our panel. And again, I'm Allison Squires. I'm an associate professor here at NYU, working with these great people and also director of the PhD program. And so in part with my director of the PhD program hat on, I'd like all of you to comment on how your role as a nurse informs your decisions in research, especially for those in the audience who might be thinking about making a career shift and going for PhD study. Who wants to go first? Well, Jasmine, you're the freshest out of PhD study and postdoc training, so I'm going to have you go first.
Sure, thank you. So for me, what I loved about nursing was being able to make a difference in people's lives. When I was a student and when it came to me doing my capstone, that like internship part, I had chosen to do an surgical OR operation rotation, and I did not like it because I didn't feel like I was able to have that patient contact and didn't feel like I was making a difference. So I knew that's what I yearned for. So I went to like ICU, and that's where I ended up building my nursing career. But from there, going into the PhD and being able to do research, I'm able to still make the difference that I want to make in the population that I'm interested in making that difference in, but on a larger scale. So that just like blows my mind. So that's where I would say that my role as a nurse has really kind of informed just my work in older adults and long-term care. So it's that passion, but like amplified.
Fantastic. And Anne-Margaret, you have been on the forefront of HIV research for a very long time and have really seen so many changes. And how does your practice also inform your research ongoing?
Yes, no, great question. So I began my career in HIV, as I said, in 1992, and then entered the doctoral program at Columbia University in 2007. So I had nearly about 20 years of nursing experience, and that really helped me build a program of research that I felt would be clinically meaningful for patients and for clinicians. So in spending all those years in the trenches, I dare say, with patients and listening to their concerns, I was able to think of interventions that would help make change. And in the area of HIV, certainly my focus is on adherence. And given the picture that I hope many of you did see, the picture with the person holding a lot of medications, that was reality-based. And we did expect patients to take a lot of medications. But yet today, still, even with more simpler formulations, it's still difficult to take medications. And it was really through speaking to patients and listening to their concerns that helped inform the way I look at adherence self-management today.
Thank you, Anne-Margaret.
Thank you.
Audrey, your work has had quite an impact on both policy at the state, national, and even international level. How did everything come together to make that happen?
Well, my background before getting my PhD was as a labor and delivery nurse and a perinatal clinical nurse specialist, which means that I was involved deeply in quality before I went back to school. So that has always informed the things I've been interested in doing. And I had the opportunity right after I finished my PhD to take a big risk to get involved with a group that we didn't exactly know what was going to happen, but I just had a feeling that this was going somewhere, and that was the California Maternal Quality Care Collaborative. And so I spent more than 10 years working with them and leading some of the early work that we did there. And that just really took off in a way that I don't know that any of us could have imagined, and has in fact had a significant impact on policy. But the other thing I just wanted to mention about the initial question that you had, Allison, is I really think that nursing and my experience, my clinical experience, means that I ask different questions, and really drives a different way of thinking about the questions that I'm asking, which hopefully is a little bit, just provides a different kind of creativity to the questions that we're asking.
Great. And the pandemic has had an impact on all of your areas of interest. I think Jasmine's research had the clearest demonstration of how the pandemic impacted older adults living in long-term care facilities. Anne Margaret and Audrey, what about you? How did the pandemic affect your populations of interest?
In terms of maternity care, it's been really interesting because in the beginning of the pandemic, my huge concern for maternity care was that everything we had to do to kind of lock that down in healthcare was going to cause some quality issues and some backtracking in the regular care that people receive during labor and birth, because that doesn't wait for the pandemic to be over, right? And then what we're seeing now, so I'm still concerned about that, and I think we may see some long-term consequences of some of those changes. But right now, we're seeing a really heavy impact of the Delta variant. Pregnant women are at really high risk for serious disease. And of course, the disparities that we're seeing in COVID translate and play into worsening disparities there when you put that intersection of pregnancy and COVID together. So very concerning what's happening to pregnant women now.
And because there's been a lot of misinformation out there, you can confirm that the COVID vaccine is safe for pregnant women?
The data seems very, very good there, that it's safe in pregnancy, does not affect fertility, and has a significant benefit in terms of transferring antibodies to the newborn. So that's a very important thing for people to hear more about.
And Anne Margaret, do you have a quick comment about COVID's impact on your population?
Yes, certainly. It did impact care or access to care. And many of the patients, although they do have smartphones, might not have had computers to access telemedicine and some of the other teleservices, or even the type of internet coverage that was needed to get really good quality care. So that's my first comment. The second comment with COVID and HIV, I felt a little bit like it was back to the future, because early HIV was filled with a lot of conspiracy and concerns that the treatments were worse than the disease, and a lot of misinformation and concerns about the information. So there was a lot of that floating around. So I do think there was a real need for accurate information and trust with regard to patient-provider partnerships.
Great. Thank you. And we are going to have a very protracted Q&A from the audience, but we do have one that I want to squeeze in there, and it goes to Jasmine, because the question from the audience is, what do you think about how the New Jersey governor wanted to make smokers a bigger priority ahead of older adults?
Sure. So I know a little bit about that. I'm not sure if he wanted to make smokers a priority ahead of older adults. But I think it was ahead of educators, which kind of sprung a lot of just controversy. So I believe the smokers came right at the same time as older adults. But when thinking about prioritizing, and the reason why he was prioritizing smokers, because they had a high susceptibility to the virus. But when it comes to prioritizing groups ahead of older adults and thinking about, how the numbers I just showed you within the nursing home space alone, who was getting COVID and the deaths, we really need to kind of understand, for one, who needs to be a priority, and for two, who needs to be at these tables when these decision making is being made. So when it comes to policy in government, we need to actually be speaking to researchers and those who are at the forefront when thinking about these issues that are prevalent. So that's what I would think about the New Jersey governor and just all of our officials in general, to make sure that we have the people who are best informed when it comes to making these types of decisions and who should be prioritized.
Great perspective there. And I'm going to turn it over for our closing remarks to NYU PhD program alumna Jin Jun.
Thank you. So that was a great presentation, and I'd like to give a huge thank you to all our faculty members today for sharing their research and insights on health equity. It was a great discussion, and it was very exciting to hear how your work is improving the lives of our patients. And also, I'd like to thank all the guests who attend this afternoon. And I encourage you to tune in to more of the Alumni and Parents Weekend programming today and tomorrow. And if you'd like to receive the Continuing Nursing Education Contact Hour, please complete the survey that will be mailed to you later today. So stay safe and stay healthy and enjoy the rest of your weekend. Thank you.